it's definitely interesting being on the backstage of this, but I just want to give a shout out to all of the organizers for this incredible seminar today, but the multiple ones that have been. And I am grateful to be part of this community, and to all the families who are tuning in. I just want to say thank you, because this has truly been a game changer in my career. And my what I, when we go into medicine, is we want to help people, and that altruism stays true. And I feel with these patients, I've had an opportunity to learn your stories and also intervene. So I've been charged with talking about my experience with lower extremities, and so I'll just get to it. I know we're a bit behind, so I'll try to talk reasonably fast. But we just had a great setup from Dr. Belsberg, so thank you there. All right, let's see. So I do have some disclosures that have no impact on today's talk, except to say very much thank you to my mentors, Susan McKinnon and Tommy Tung, who got me into nerve surgery, and then for Scott Kozin and Dan Zodolo, who got me into the patients with AFM. And I do want to say the same for Dr. Belsberg, who's been a true guide to my career. And last but not least, I do need to give a shout out and thank you to my patients, as well as to the parents who have allowed me to learn and to help tell their story so that we can help others. So we don't need to go back to the basics of it. We just heard this great talk about it. But the idea is, when the nerve is injured, there is a sequence of events that happen. And our regeneration rate is true, which makes us all nervous when thinking about how can we intervene in a timely fashion, and a surgical intervention, when is the right timing, versus doing the nerve surgery versus the tendon surgery. And I have a lot of thoughts on that as well. But it is that we're limited in our regeneration rate, and the time is muscle. A concept that I also want to bring in to play here with nerve transfers is that we're not looking for 100% of return of function, because we know from rats and from animal studies that you can lose a lot of motor neurons, or those cells that control the nerve. We can lose up to 80% and still have pretty good function. And so when we apply that to patients with nerve transfers, is that we're just trying to get people back up on this hill. The goal is to get them something when they have nothing. And that is where I think nerve transfers have zoomed up to the top of our algorithm when we approach patients with nerve injuries. The principles of a nerve transfer we just heard, but I'm going to put it into a cartoon form here, where green is our donor. I'll talk about the donor. The donor is the set of nerves that are working and that the patient or child has control over. The recipient is the muscle that we think is of higher need, less, that's more function is necessary, like to bend our elbow, the biceps is more important. And if we have multiple that bend the fingers, then we can steal from it. Same thing with the lower extremity. If you have toes that wiggle, but you can't stand, the idea is I can take some of the wiggle to give us motor muscle more proximally. And so when we think about the terminology, donor is the nerve that's working. We're going to donate it to what's not working, the recipient, and that's where we're going to try to get our target and restore. So we just heard about Christoph Oberlin. I would be remiss to not mention Susan McKinnon, who also later that year published upon it. And why I bring this up when I'm supposed to be talking about lower extremities is that this is what I based all of our work in the lower extremity on. It was the great work of these giants in the upper extremity who focused on getting inside the nerve. So as you can see with these circles, this is just a cartoon drawing, but you can get into all these little parts of the nerve that if you tap on it with the electrical stimulator, the muscle jumps. And it's from using these fascicular anatomies, so that's the part of the nerve that we just heard about with Dr. Belsberg, that we can tap into to give us function to the recipient, that motor that we need to stand, to straighten your legs, and potentially to walk. So here, and you can see this is just giving outcomes. These are not patients with AFM, but honestly, it's just that you can get near normal function from nerve transfers. And it's because of that near normal function that we can attain. In my, growing up with Susan McKinnon, who is a nerve specialist, well-renowned, we are doing nerve transfers all over the body for all over different kinds of diagnoses. And so when Dan called me up to ask me what would I do for a child that he's seeing in his office that has lower extremity paralysis, I was just winging it, being like, well, I think we could go after this. I never expected the patients to come to me. And when they did, it was, it's its own blessing in disguise. So now let's talk about what we know. So I love that I'm going to parallel off of Dr. Bellsberg, because all of those studies we're talking about with nerve transfers, they exist in the literature. They just didn't get the excitement until the 1994 article, and then we see this huge exponential shift of interest in the literature. And you can see that with AFM, we have a little ways to go, bringing it up to describing nerve transfers for this population. And so what can we do? It's first to sort of set the stage of why I got involved. It is at Washington University in St. Louis, we had all of these nerve specialists, and I was new to the game. So, Dr. McKinnon was already doing brachial plexus, and Ida Fox was doing spinal cord. And so where I still had an opening was in the lower extremity. And so that's where I focused my expertise and was successful with this. And so it made it, okay, not so strange to think about just a new application. And so thanks again to, Dan and Scott, who have a nice referral base to their hospital, that they were just said, hey, what would you do? And then there they came. So in the next few slides, it's to talk about my experience. It's to show what is potentially possible. And I, again, am grateful for those who are allowing me to tell their story so that we can get the word out. I mean, that's what it comes down to, that maybe we can help these patients too. So I got involved in 2017, and I refer to the groups as cohorts because I do think their presentations were a little bit different, but really it's just how I can separate them from my follow-up. All of the patients, as you well know, have a different presentation. The right side does not look like the left side. The right arm doesn't mimic the left leg. It is so variable on these patients of what they had. A child I saw today just has weakness of a left shoulder, and so, but was initially quadriplegic. So I think that the reality is you have to be a bit flexible, and these surgeons that we've talked today are getting that. And I ask the parents to be open to that too, because we don't have enough numbers to say this is what has to be done. And the excitement is the opportunity to give back using founded principles based on the upper extremity. And so that's what we did. I used these upper extremity principles, looking at the sciatic fascicles as well as pain. And so I'm going to touch upon decompressions and be very clear with what I believe about decompressing nerves. I decompress nerves not to restore function, but to restore the space through which the nerve passes to help with pain and discomfort. By doing that decompression, it also allows the floodgates to open. So you think about 4 lanes on a highway, gets compressed to 2 lanes, all the traffic backs up. You think about these kids, they've had a spinal cord injury, they're swollen, they're in the bed, they're stiff, and then they're paralyzed. So the nerves are going to swell just because the soft tissue does, but that space through which it passes fixed. And so when I think about my exam on the patients, the tenderness and opening up, it's because if we open up the channels, we go from 2 to 4, we know the sensory nerves are working in these kids, that why would that not to help? And so that's sort of the differentiation of what I'm talking about with decompression. From the 2016 cohort, I operated on a total of 13 patients, 10 with lower extremities. I think the key thing to draw your attention to is that I didn't see them and operate on them with an average of 14.9 months from diagnosis. 10 months was the earliest that I was able to intervene with these children, and I have follow-up on 8 patients. The 2018 cohort, because of the incredible activism of the parents and the physicians who are involved in this workshop and the CDC work group, we were able to get to see these patients sooner. I operated on 33 patients in 18, 16 with upper extremity, 17 with lower, and it's 17 patients, but most were bilateral on both of these. So I don't have total number of limbs, but it is many of these patients, and these were separate patients from upper and lower. Some had upper and lower, and I would do them all at the same time. But 10 months, we got them at 10 months. And I think that's the exciting part, is that, okay, well, where can we be? And so I put in this big blocks. I didn't want to forget. I do agree with Dr. Belsberg that I think the window is probably even earlier than that, because as I talk to the parents, and if I get involved early, I'm seeing them plateauing by 6 months. And so my sweet spot, and I think, is where I'm sitting now, and again, I love the discussion afterwards in our group, is about 6 to 9 months. I think if you're operating before 6 months, there's still recovery being seen, but it is all individualized to the patient and what their experience is. And we can't just put a blanket, this is what it is. So we have to keep everybody individualized. What did I focus on? I focused on hip stability. We heard about from Dr. Watkins today about what to do about the hip, and there's not great options, but we know it really matters. And so my priority was, if I could stabilize the hips, then anything below the leg could have a brace, and the patients can work on standing, transferring, and then eventually, the Holy Grail, to be able to ambulate. Next, I focused on knee extension and then knee flexion. What did I use? My donor options. So the donor, again, is what's working and what I can take to intervene and move it to what's not working. And that was the sciatic nerve, which is this big nerve that's up at the, comes out up at the hip, and it has all of these fascicles, which are those round little balls. And you can tap on each one of them and find, okay, these go to toes down, these go to toes up, this goes to ankle. And so those were my priorities of whatever was stronger in the patient, I went to hip. Whatever was not as strong, opposite to it, I would go to knee extension. And so it isn't such a formulaic algorithm. It is very individualized of what the patient needs and what the patient has. So again, talking about the decompression, this week actually just received my acceptance letter of what decompressing the nerves at the femoral triangle can do. Many of you have called me to talk about, well, can you decompress my patient? Again, it's dependent on pain, tenderness at the site, and doing these decompressions, I have seen recovery. And I think those are more of an ischemic conduction block that can happen. And so I do think there's benefits from a motor as well as for sensory. But if you are getting surgeries done by your surgeon, they are decompressing by the way of just doing the nerve transfer. So it doesn't need an additional decompression if you've had it, because to expose the nerve, you've freed it from this tissue and scarring, which is, the fibrinous tissue, I should say, not scar, that is compressing the nerve. So here is a patient of mine, 4 years, 15 months prior, right leg is paralyzed, toe motion is intact. She's able to use the left leg, and I'm asking her to do all this movement, and she's doing it with her left leg, but the right leg is flaccid. Here are the incisions. I get asked this a lot. Where are you going to make these cuts on my child? Is it going to be at the foot where you take the toes? No, everything is up high because of how I can tap into the nerve way up at the hip. The incisions are small. I made these a little bit more dramatic so they could show up on the photos. Intraoperatively is where we can tap on the nerve and see the nerves and the toes move, right? So And again, turn away if you don't want to see intraoperative photos, but you can tap where the nerves are and get the toe motion. And here I'm in the leg, but back here I'm up at the bottom. And so that's where I can find what I want to transfer way up high. So that's the nerve. So again, turn away if you're getting sick. But the toes can move. I can identify it there. And fortunately, with all of my patients, I have not downgraded their function. So the options are for using fascicles to restore the femoral nerve, using them to restore the gluteal nerve, using them to get hamstring function, which is knee bend. I don't need to get into the details, but they're there. My paper is in publication, sort of in that mix of all these revisions, but hope to have it. And why did I get excited? So I stopped with 10 in the first cohort because I wasn't sure it would work in these patients for this new diagnosis. And then you all got involved. So everybody talked about AFM because all of a sudden it's going to have a second wave. And this is where it comes. So in the last 2 minutes, I just want to show some inspiring stories. So here's Brandon. I was getting called by everyone around the country that you have patients, and there's this little boy we saw on TV. I had no idea this was happening, but then it became really real. And so Brandon's just one of many who were first at all times wheelchair bound, but because of the determination of the child, because of the commitment from the family members to get them to the therapy, and it's exactly what we heard from Dr. Bovey about the growth of all the other muscles continue to happen. Here at 2 years, Brandon's walking. And this craziness that comes, and I give it all attributing to the Facebook page and the parents and the advocacy that you give, to the groups that are supporting, all the sponsors for this program. I say thank you because our patients are benefiting from it. Our outcomes, I would love to say that everybody had incredible outcomes. I can tell you that there's muscle function. It's variable. I would say MRC grade 2 is what most patients are getting. But what I think is important to note, 6 out of 8 are ambulating with bracing and modalities, whereas we're previously wheelchair bound, and 5 out of 8 stand independently, can transfer with or without a brace, it depends. And so those are the outcomes that, yeah, it's not normal, it's not perfect, but it is something. So here is Miss Cammie. I think this is where she was right at about a year using a cane. And then here are some other children that have been most recently, they're walking. This was a decompression and a nerve transfer. You can see, here's Alfred. This is this last week now with telehealth, what we can do. It's very exciting seeing him stand, walking with a walker. Here's Cammie at 1.5 years. And this past week, 2 weeks ago, you can see where she's walking and is figured out, because they're just genius little kids, can figure out ways to maneuver. And so again, not making anything normal, but inspiring by what these kids want to achieve. I think we can make it happen. So nerve transfers are an option for the lower extremity. Pain shouldn't be ignored in AFM. I think these children have pain. I think they definitely have pain at the time of their diagnosis. Not restoring normal. For those who have nothing, a little is a lot. And be critical of the results. I'm certainly being critical now, and that's what my conversation stemmed around with my patients. Thank you very much. I have new contact information. I hope you all can get this. We've built a great team, and I would now have the pleasure of introducing a good friend of mine, a colleague, a friend, a referral pattern. I thank him for getting me involved in this patients. And here is Dan Zotolo to talk about surgical options for recovery of diaphragm function. Thank you so much.